Hello, good afternoon, everybody. And we're just waiting for a couple more people. The number keeps climbing. But just basically to start, I think we should kick off now. Welcome back again to our second Inneg webinar. Today, we have the wonderful presence of Dr. Rajiv Malhotra, a consultant, anaesthetist and pain medicine specialist. And he's been a consultant since 2015 and obviously doing expert witness work for the last sort of 6 months or so when he began his practice. And very interestingly, before I pass it over to Rajiv, Dr. Malhotra, is that he, quite different from most pain medicine experts, has a particular clinical interest in spinal and nerve related pain management, which is obviously the topic of his conversation today. These sessions are brought to you by Inneg, and for those who don't know us, we are a specialist agency which supports clinical negligence and serious injury solicitors. We do a whole range of services. I won't go into them, but predominantly it's the sourcing, managing and supporting solicitors in relation to the medical expert witnesses, particularly for high value and complex cases, which is the predominant work we do. So if you do have any inquiries for Dr. Malhotra, or you have any other niche or difficult to source cases on your desk, feel free to reach out to us in the coming days and we will look to assist you. Housekeeping, there is a Q&A function at the top and a chat function. We would love to hear your questions. After Dr. Malhotra has spoken, he will answer any questions you can. You can either ask them today in this forum, or alternatively, you can email us afterwards with a specific question relating to a case you might have, and Dr. Malhotra can obviously give a private response to you in relation to that. So without further ado, if I can pass you over to Dr. Malhotra, and thank you very much for your time. Please take it away.
Lovely. Thank you very much, Leo, for that introduction, and good afternoon, everyone. So I'm going to talk to you a bit about spinal pain management, and hopefully you'll find it of interest as you're probably tucking into your lunch. So first of all, I'm going to talk a bit about myself, but I promise you I won't turn it into a soliloquy about all things great about myself. We'll then move on to talk about spinal pain, so it's kind of my bread and butter. I'll then talk to you about some national guidance that may be relevant to yourselves when you process a claim. And then we'll go through some case discussions that will hopefully show why spinal pain is very difficult to manage, and it's important that we gain context when we examine patients from a medical legal point of view. So, as Leo said, I've been a consultant up in Liverpool in pain medicine since 2015, and love my job, do a lot of NHS and private work, and I see about 30 to 40 people every single month who have a variety of pain conditions, and on top of that I perform about 30-40 interventions per month, so very busy in the pain world. Very lucky to have done an accredited one-year fellowship in pain medicine up in Liverpool, passed some exams that were laborious and difficult, but thankfully that's all in the distant past, and I am a member of the faculty of pain medicine, which is kind of our governing body that outlines the requirements to be a pain medicine specialist in the UK. As you can see by my list of qualifications, I've really targeted things that have the most number of letters that I could find, and that ticks all the boxes, I suppose, of a megalomaniac, but probably the ones I'm most proud of are the ones that are probably rarest amongst pain medicine experts. So I have a dual master's in medical education and in business administration, and may just show that I've got too much time on my hands, but they are areas that were quite interesting as I pursued those scholarly activities. In terms of specialist interest, as Leo said, for most pain specialists, about 40 to 50% of their work focuses on spinal pain, but for myself, it's up at 80 to 90%. So I sit within a spinal surgical unit, and that means the majority of my work comes from the spinal surgical team. That means that most patients I see struggle with spinal pain, whether it's the top of the spine or bottom of the spine. And it means I'm integrated in their service. So I have really good working relationships with the spinal surgeons and our radiologists and physiotherapists, which means that I can approach spinal pain from a slightly unique and different place, given where I currently sit in my clinical practice. My main interest is in nerve-related pain, and that's a lot of different types of nerve-related pain, but given where I work, it is mainly spinal nerve-related pain, and that's as a result of degeneration or trauma or surgery. As Leo said, I've started my medical legal career and quite interested in pursuing that and finding that very interesting and something different for me. My big passions are jiu-jitsu, so I'm orange belt at the moment. Hopefully, I'll go for my green belt in the next 6 months. To give you an idea, to get to black belt will probably take me till early 50s. But the way that injuries accumulate and recovery from injuries kind of prolong, I may have to push that back. And I'm lucky enough to have a season ticket at Anfield. It's a bit bittersweet with it being Jurgen Klopp's final season, but hopefully we can get some more silverware to give him a good send-off. And it was quite useful us coming out of the FA Cup this weekend, so I'm quite happy with that, and hopefully the best team in Manchester win that on FA Cup final day. Very active in research, and I've produced lots of different papers and book chapters that I've put there. I've produced 3 different articles on pain medicine in the last 2 years, but the one that's probably of most use from a medical legal point of view is highlighted there. So it's a review article that talks about radiofrequency ablation, which you may recognize as burning of the nerves, and it's very, very common treatment strategy for people who have spinal pain, and often forms part of an opinion as from a medical legal report. So burning of the nerves is very useful for people because it has the best evidence base of any intervention for people who are struggling with spinal pain, and it involves burning nerves that supply joints in the spine that are often a source of pain, because we know that wear and tear in joints, and if you think of lots of other joints like knees and hips, can cause pain. Exactly the same in the spine, and you can burn those nerves and often produce at least 1 year's worth of high quality pain relief. And then patients can do exercises and get stronger and fitter. So normally it does form part of a management plan, and this is a quite useful, hopefully, review article outlining why it's of use and some of the best techniques for it. In terms of managerial responsibilities, probably the thing I'm most proud about is being regional advisor for pain medicine. So this is a nationally appointed post from the Faculty of Pain Medicine, and it means that I'm in charge of pain medicine training in my region. So I structure the pain medicine training, and I ensure that the standards for a pain medicine consultant are met through all the different departments in the different hospitals that I oversee. There are other roles that are quite useful from a medical legal point of view. So I'm clinical governance lead, so I deal with a lot of critical incidents or patient complaints. So it's useful in terms of navigating that pathway. And sitting on the Medicines Management Committee gives me good oversight of what the legal and professional requirements are for drug-related issues such as opioids or gabapentin or pregabalin, because I'm sure you're aware, huge epidemic in opioid and gabapentinoid misuse in the community. And I'm honorary clinical lecturer of my alma mater up in Liverpool. So that's enough about me. Let's talk about what you're here to hear about, which is spinal pain. So this is quite a useful graph. So this graph shows the global burden of lower back pain in different populations across the world. So it shows at the bottom lots of different age groups, 20 to 29 and so forth, going up towards 80. And it shows the degree of burden of lower back pain using DALYs, or D-A-L-Y. This is disability adjusted life years. It's very commonly used now to describe the burden of disability associated with medical conditions. And a DALY is the amount of time that someone spends in their life that is reduced due to either early death or less than full health. So it shows how much disability is related to that pathology. As you can imagine, lower back pain, it's fairly prevalent in terms of disability, particularly in Western Europe. So it's not a global pandemic, but it really is a problem in Western Europe particularly. And it's difficult to say exactly why, but it's likely to be an interplay of things like mental health. So depression is very prevalent, other comorbidities such as obesity, other lifestyle factors, and other socioeconomic or poverty-related factors. What's even more interesting is that if you look at studies, the amount of degeneration or the incidence of degeneration on spines hasn't increased anywhere near the rate that the disability has. So it's not as if just more people are having degeneration or pathology on scans needing more surgery. It really is that back pain has persisted, but it's just becoming more symptomatic and more disabling, particularly in Western Europe. So when one assesses patients with back pain, it's important to remember that biopsychosocial approach is crucial, because that explains why someone has increasing disability, either naturally through disease progression or after an index event, than other people. And that's really crucial when a medical legal expert examines such a patient. And it's also then important that we think of why certain people are at higher risk. So is it that in Western Europe we're having more depression, more psychological problems that are leading to this increased disability? And then we may open a bit of a can of worms in terms of vulnerability, and that's an important thing to assess as part of a report. The problem is spinal pathology is not straightforward. You can't just do an MRI scan and then say, well, someone's got a disc prolapse, therefore they're far more likely to get disability as a result of this disc prolapse. As you'll see on the next one or two slides, it's not as straightforward as that. And I think that from a medical legal point of view is a very common pitfall that people can run into. So this is a widely quoted study, and it forms the basis of a lot of medical legal reports. So it was a huge analysis done in 2015. So the authors took 33 studies that looked at the results of an MRI scan in patients who do not have symptomatic back pain. So they had MRI for some other reason, and then the authors looked at the spine and thought, well, let's see what's happening with regard to the spinal pathology in these people who are asymptomatic. So it was a huge study and very interesting conclusions. They say that most people who have back problems on an MRI scan are asymptomatic, and the rate of asymptomatic spinal disease is very high. So this says that if you take 10 people at a bus stop and scan all of them, people who have pain and don't have pain are as likely to have the same findings on an MRI as due to chance. So just because you have a disc prolapse doesn't mean you have pain. Just because you have a disc prolapse doesn't mean you're going to get long-term back pain. It's much more nuanced than that. And what's even more interesting is that if you look at MRI scans for disc bulges, so say someone comes to see me with sciatica, I do an MRI and show a large disc bulge. I meet them at dinner 2 years later, they don't have pain anymore. If I were to repeat that MRI, there's a 50-50 chance that that disc bulge is not near the nerve anymore. So the correlation between symptoms and disc bulges and MRI is not consistent, is non-linear. You can't induce information from an MRI. That's why, as a medical legal expert, it's really important that you integrate those MRI findings into the biopsychosocial model, that you use appropriate history and examination, and you need to know what you're looking for, because a lot of changes that happen as a result of age are normal. So when you present a case with reduced lumbar flexion, that is normal changes as we get older. I don't know if you can all still touch your toes, but I know my 4-year-old son doesn't find it difficult to sit touching his toes for hours. I can't do it, even though I stretch a lot with jiu-jitsu, but that's enough about me. So appropriate assessment of these patients is important, and detailed assessment of GP records, physiotherapy records. They are a mine of information about what's actually happening in a spine, because it shows an objective assessment of how patients react to interventions over time, because often physiotherapists will see patients several times during their treatment. So if we look at the incidence of asymptomatic disc degeneration, I've put the results for 20-year-olds here because it's quite startling. We talk about age-related changes, and we kind of assume age-related changes means 40, 50, and that's coming from someone who is in their 40s, early 40s, but still 40s, unfortunately. 1 in 3 20-year-olds is walking around with degeneration in their spine. So that's really what we mean by age-related changes when it comes to spinal pathology. And one of the most scariest spinal pathologies is cord compression. So this is a type of cauda equina syndrome, but it happens a bit higher up in the spine, something that is a medical emergency or a surgical emergency. 24% of the population walking around without symptoms has cord pathology on an MRI scan. So it shows that overinterpretation of MRIs and medical legal reports is common and is difficult to support given this study from 2015. What's even more interesting, though, is the nuance behind it, and that's the area I'm most interested in. If you look at the bottom statement, annular fissures or disc tears, 29% of 80-year-olds. So it's actually a really low incidence. If you think disc bulges, 90%, degeneration, 85%, but annular fissures, only 29%. So if someone does have a significant trauma to their back and then develops an annular tear or an annular fissure, you may be able to say, well, actually, they were less likely to develop an annular fissure or tear unless they had that index event, because long-term data shows only a third of people actually develop annular fissures. And then you can take a step further forward. So actually, if there's an annular fissure that's central, as in the tears in the middle of the disc, much less likely to be associated with pain or pain down a leg. If you look at that annular fissure after the index event, and it's a lateral annular fissure, so it's more towards the side of the disc, far higher likelihood of pain and chronic pain potentially requiring surgery. So these are the nuances that one needs when they're looking at MRI scans, and they really need to use it only as part of an overall and complete picture. So if we look at why some people develop chronic pain after an index event, some people don't, particularly when it comes to spinal pathology. This slide is really useful, and this is called the fear avoidance cycle. It's very commonly used in different pain centers, and we use it a lot in our spinal unit. So an injury happens and a pain experience occurs. So for instance, I'm getting ready in the morning for work, I bang my funny bone and it causes pain. I know that that's not associated with any significant trauma, my arm's not going to fall off, I can kind of confront it without any fear and then move on to recovery. And for a lot of people, this is a normal pathway for them. For some people though, they move the other way. They get into the cycle of pain catastrophization. Catastrophization is when someone puts a negative spin on events. So they think, actually, I've actually broken my elbow here, or I've damaged a nerve, and that's going to give me nerve problems forever. And often you're more likely to develop this catastrophization if you have negative affectivity. So if you have some kind of psychological vulnerability to this. So it could be based on depression. And we know that 65% of people who have depression also struggle with pain. It could be that it's just life circumstances. You've lost your job, you've fought with your partner, you've got money worries, employment issues, and you think that this is just the straw that breaks the camel's back, and why has this happened to you? You then start to become fearful of moving your arm, so you hold it close to yourself. You don't write with your right hand anymore, you write with your left because you think you're going to damage it more. But all that happens is you become hypervigilant. So you just start to think about this funny bone and what damage you've done and the fact that you can't move it. Then the muscles get weaker, the joints get stiffer, the ligaments get tighter, and suddenly it's not just the funny bone injury that's causing problems, but this multitude of musculoskeletal problems that are starting to affect your life. You don't really go out anymore because you don't want people looking at your arm because you think it feels funny or it's got a lot weaker. You couldn't go into work because there's no way you could sit at a desk typing with the pain that you've now got in that right arm. And you can see then how disuse and disability becomes a bigger issue. And unfortunately, if your arm has got weaker and the ligaments are not as strong and the joint is less supportive, you're more likely to develop further pain experiences. And this cycle is how people end up with chronic complex pain. So one thing we know is that early intervention is something that can be done to break that cycle, and identifying people at risk of catastrophization and avoidance and hypervigilance is really important. An example is in whiplash injury. So we know that half of people who have a road traffic collision leading to a diagnosis of chronic whiplash associated injury have post-traumatic stress disorder. And we know that early psychology intervention can be useful in reducing the duration of whiplash injury symptoms. Screening for it is not difficult. There's an injured trauma reflex screening test. There is a questionnaire that you can do, and it identifies those at risk of post-traumatic stress disorder, and therefore those that can be accelerated in terms of their treatment and management of this. And that's a really good example of using this to using a technique to break the cycle. What's also interesting is that people who have pre-existing chronic pain conditions are much more likely to develop chronic pain after a pain experience because they're more likely to go into this fear avoidance cycle. And when you do a medical legal report, it's not uncommon to see a pattern potentially of back problems, musculoskeletal problems, or psychological problems that mean people are far more likely to develop chronic pain after an index event. But that's much less likely to explain problems if it is a serious incident or if there's a high collision with regard to the road traffic injury. So just go to show why some patients develop chronic pain. And this is one of the models. There are other models that can be of use. And the fact there are multiple models shows that it's actually an area that is difficult to pick out. But often, if you look through the notes, you can see some reasons and some explanations as to why people develop chronic pain. And obviously that significantly affects prognosis. With regard to lower back pain, There is national guidance, and this can be very useful as part of your medical legal report in terms of treatment options. And it's probably more useful to start in the no column. Routine imaging isn't recommended, although is often done by at the stage that someone is going through a legal process. Repeated spinal injections are not recommended. So gone are the days of going for what we used to call top-up epidurals. Can't do that anymore. Gabapentinoids and pregabalin are not recommended for lower back pain, but there's a caveat in that, and I'll use the word caveat a lot. We used to think that lower back pain has no neuropathic or nerve pain related element to it. We thought it's very much just discs that are worn or joints that are worn. But actually, if you use neuropathic pain questionnaires, you'll see that at least half of patients or clients who have lower back pain have an element of nerve-related pain. And that's really important because we know that nerve-related pain has a much worse prognosis and is far more difficult to treat than non-neuropathic pain. And if you identify neuropathic pain using a questionnaire, you can then recommend drugs like gabapentin or pregabalin that may benefit these clients because they are quite useful in the management of neuropathic pain. So that's probably number 5 of the caveats that I've discussed so far. And TENS and acupuncture don't form part of the national pathway for the management of back pain. In terms of the yes column, a lot of these you will recognize, and I'll just highlight that radiofrequency ablation, which is the topic I talked about at the very beginning, is something that is recommended according to NICE. These are very common treatment strategies that form the management of patients who have spinal pain, but also part of a medical legal report. And I'll just highlight what things I think are most important. So in terms of diagnoses, there are a number of different diagnostic criteria that people can use. The most useful one I find is the International Classification for Diseases. Volume 11 was published in 2022, and this is the internationally agreed list of diagnoses for medical conditions. And I think what's useful is if pain medicine experts and other experts use the same diagnostic criteria, because that will allow comparison of different reports. It will inform different reports if medical legal expert reports are shared. And it also informs prognosis and potential treatment options. And the ICD-11 is a fantastic diagnostic list of criteria. And what's most useful is ICD-10 and 11 received a lot of input from the International Association for the Study of Pain, which is one of the international organizations that talks a lot about pain. And they had huge amounts of input, which I'll talk about on the next couple of slides. In terms of causation, I would say as a pain medicine expert, if the main causation question focuses on pain and a pain diagnosis, that I would be best placed to provide details on causation. But often, in cases that I do, a spinal expert or an orthopedic expert has already commented on causation, and that's something I'm quite familiar with, having done lots of reports with spinal surgeons who I work closely with. And then prognosis, that's probably the area that requires most nuance because there's a lot of detail that comes into giving a prognosis report as part of a medical legal report. But we'll talk about that in a second with the cases. Next 2 slides, just going to introduce you as to why I think the ICD-11 is a great tool for providing diagnoses as part of a medical legal claim, but also in my NHS and private practice. So chronic primary pain is a diagnosis that never used to exist when I was in med school and didn't exist even when I was training to be a pain specialist. It's now a diagnosis that is widely recognized. And one may remember the term chronic pain syndrome that was quite commonly used in medical legal terms, and that doesn't fall within the ICD-11 classification system, but chronic primary pain does. And chronic primary pain basically says that a client or a patient has pain in multiple different areas associated with significant impact on their quality of life and mental health. And it says it is multifactorial. There are lots of things that will impact this, but what it isn't is an explanation for what problems the actual pathology shows. For example, if someone has a disc prolapse, as I've said, that's not necessarily associated with significant symptoms or emotional well-being problems or disability, because it's as common in asymptomatic people as it is in symptomatic people. But someone may have a disc bulge, then a road traffic collision, increasing pain afterwards. So one could easily argue that this is the development of chronic primary pain, and that person now has more widespread pain, emotional problems, psychological problems, and disability as a result of that event exacerbating things. And chronic primary pain may be a very useful diagnosis in that case, and I think it's going to be used more and more as time moves on. And then bodily distress disorder. So this used to be known as somatoform disorder or somatic symptoms disorder. And it's basically when clients or patients come with a variety of medical problems. They have multiple interactions with primary and secondary care physicians and other members of the healthcare community, but no obvious serious pathology is found, but the person is convinced that there's something happening and it's causing huge amounts of emotional distress and an inability for them to live a functioning life, and often forms part of the psychology opinion, but it's something that I see quite a lot of in my practice. So it's something that I am able to recognize. And again, it may be something that you can identify in cases that you're involved with currently. So we'll move on to the cases, and this is probably the area that's most interesting. So 47-year-old female, road traffic collision with significant pain afterwards, depression since the index event. Interestingly, a previous road traffic collision with neck pain, MRI shows cervical degeneration, but only mild in this 47-year-old, and the pain was completely resolved. Of course, this person had an MRI scan, no new changes were found, so there's still the ongoing mild degeneration. And it's important that we get details as to what happened around the index event, and often pictures of what's happened can be quite useful in determining the size of the insult that will have happened to the cervical spine, as there's lots of controversy about low speed whiplash claims or low speed neck disease. But what we know from multiple studies is that even low speed collisions can cause changes in the architecture of the cervical spine. Certainly 10 miles an hour is enough to cause changes at both ligamental and muscular level within the spine, and potentially changes within the facet joint. So that's why details of that matter. The MRI showing no new changes is entirely consistent with whiplash, and it can't be used to show that there isn't evidence of either pain or something like chronic whiplash disorder, because it is commonly normal. So these would be the diagnoses, and again, I've used the ICD-11 classification, and I put it in hierarchical order. So the most important diagnosis at the top, working one's way down. And you can see that PTSD is written in brackets, as often it will be based on interview with a psychologist, but there are screening questionnaires that one can do, and it can form part of the diagnoses of a pain medicine medical legal expert as well. I think what's useful is producing the list of diagnoses, because that will inform the treatment options that you have. So there are very common treatment options here, but because I've given a diagnosis of cervicogenic headaches and myofascial pain, another treatment option open to us is occipital nerve and trapezius muscle injections, which may be useful for certain patients who have chronic whiplash associated disorder. You'll see radiofrequency ablation is again mentioned as a very common treatment strategy for people with whiplash associated injury, and clearly psychology input is going to be important. We know that most people who have neck pain after a road traffic collision improve. So most people within the first 3 months show significant improvement. There are numerous questionnaires that one can do to predict prolongation of symptoms, and normally that means more than a year's worth of chronic pain and suffering after a road traffic collision. Common ones are the Quebec questionnaire and the Neck Disability Index, and for this client the Neck Disability Index score was really high, and that's a great tool because that is 8 questions, don't really focus on pain, but a focus on what the pain means someone can't do. So in terms of household chores, getting dressed in the morning, going to work, really good and really simple to understand, that explains quite a lot about why people have prolonged pain after road traffic collisions. And there's definitely prognostic indicators for prolonged recovery or poor recovery in this initial case. And we know that once you get to 1 year post-index event, recovery is normally fairly minimal. So we've put here mild to moderate, and that is because there may be new treatments such as injections or psychology input that hasn't happened before, but normally resolution of symptoms doesn't occur. We then need to talk about the fact that there was a previous road traffic collision and some cervical degeneration. So what we know is that cervical degeneration is not a risk factor for prolonged whiplash-associated injury. We know that cervical degeneration is very common. If you remember back to a couple of slides ago at the beginning, a third of people at the age of 20 are walking around with cervical degeneration. So it's incredibly common, and it's very unlikely that cervical degeneration will result in significant pain and suffering over the course of someone's life, unless there has been an index event. What I found useful is to separate hard injuries or hard changes with soft changes, particularly with spinal related trauma. So cervical degeneration is a hard injury. So the degeneration is in the bones and the joints, and these are hard structures you can almost knock on like a table. Most whiplash associated injury is in soft tissue. So this is in the muscles and the ligaments surrounding the spine. And I think it's quite useful to identify and separate the two when you're giving prognosis. And I think that can be quite useful as part of your medical legal report, and explaining why pre-existing cervical degeneration doesn't mean that there's been any acceleration. And this was an interesting study in 2019. And again, it confirms that degeneration is not associated with non-recovery. But again, this is the catch, that actually you need to understand that degeneration is a fairly global or large picture term. If you get down to the nitty-gritty, there may be changes on an MRI that predict prolongation of pain and whiplash associated injury after a road traffic collision. So if a report comments on the fact that there is facet joint degeneration, then that may be associated, and it's a moderate evidence, so it's not bad when you think of the evidence levels, may be associated with prolongation of whiplash symptoms. So again, it's really important that you look at the detail of a radiology or MRI report. And I look a lot of reports and discuss it with the spinal surgeons, but identifying this detail is beyond my remit. So sometimes getting a report from a radiologist as part of your medical legal review can be really useful. And scrutinizing the GP and the physio records are essential in determining what problems people were having with the underlying pathology previously. This person had complete resolution of symptoms. Very unlikely that that is anything to do with their now more long-term chronic pain problems. But what if we say, actually, let's move the case on and say the person who had this index event now complains of fairly widespread pain, changes in their mood, their sleep, their concentration, walking with a crutch. So symptoms that were previously characterized as fibromyalgia, ICD-11 would characterize it as chronic primary pain. So there was some thought that whiplash injury was definitely associated with development of fibromyalgia after the index event. But there was a large-scale study and an editorial accompanying it that showed that there's no strong relationship between whiplash injury and fibromyalgia. And I think what's crucial in this kind of scenario is that the medical legal experts uses validated screening tools for fibromyalgia, both pre-index event and post-index event. It is not uncommon to look through GP records and actually be able to meet the criteria for fibromyalgia and show that it was there previously. And so it may have been a vulnerability to developing more complex chronic or long-term problems with whiplash. So it's very important that you can use screening tools to identify what's happening before and afterwards. And post-injury fibromyalgia or chronic widespread pain is a good reason to do that as part of your report. And for the second and final case, so the dreaded words cauda equina syndrome. So certainly in our spinal unit, they are dreaded words to hear. So it's a 38-year-old female diagnosed with lower back pain and sciatica due to a disc prolapse. Was aware of red flag symptoms, but unfortunately over a 2-day period developed increasing red flag symptoms. And red flag symptoms alert clinicians and healthcare professionals to the presence of or potential presence of cauda equina syndrome, which is where a disc is starting to press on nerves, causing permanent nerve damage. Unfortunately, there were delays in primary care, but eventually the patient and client was referred onto the emergency department and had an MRI scan, and this did show cauda equina syndrome. Fairly prompt surgery, but unfortunately long-term neurological and psychological consequences as a result of this delayed diagnosis and this now permanent nerve problem. Depression, anxiety, unfortunately, are very common in this condition, and there's also the loss of occupation. The diagnosis is quite clear, but It's important to identify other things. So central neuropathic pain is another diagnosis that I gave to this client. And again, that opens up other potential treatment options. And we know that neuropathic pain has a worse prognosis than non-neuropathic pain. And again, diagnosis of the bladder problem necessitated referral on and an opinion from a urology surgeon. There's national guidance on the management of cauda equina syndrome, and it sits as part of getting it right first time process, or GRIFT. And this is work done by the British Association of Spinal Surgeons to really identify what steps need to take place for the management of cauda equina syndrome, given that there is fairly potentially disastrous outcomes if there's a delay in diagnosis or a delay in MRI or a delay in surgery. So the red flag symptoms are published. All patients and clients should be given the markers for identification, and should be advised that if they have these symptoms, they need to contact a healthcare professional and undergo an urgent MRI scan. The GRIFT report identifies problems with getting an MRI within 4 hours, but the Royal College of Emergency Medicine state that it should be done in 4 hours. But in a lot of hospitals, there isn't 24/7 MRI cover. So the Royal College recommends that if someone presents with potential cauda equina syndrome, but it can't be done in 4 hours, they should be transferred to a centre that can. So they may necessitate a transfer of someone with suspected cauda equina to a centre with 24/7 MRI cover. And if they have cauda equina, it is emergency surgery, so it normally takes place within 24 hours of the MRI being performed. And there are plans within the guidelines for follow-up, often with a spinal injury unit. In terms of treatment, there's no interventional procedure, there's no injection, burning of the nerves doesn't work for cauda equina syndrome. But because we identified neuropathic pain as a consequence of this, a trial of anti-neuropathic painkillers was thought to be useful. So drugs like pregabalin and gabapentin, although there are multiple anti-neuropathic pain agents. And obviously this is a fairly global insult and global changes to this person's quality of life, so other reports were recommended. In terms of prognosis, mild to moderate improvement is all that can be expected. There's not going to be a resolution of symptoms, and certainly returning to that occupation is going to be difficult, and certainly there's going to be a disadvantage in the open market in this case. So what if we changed the pre-existing injury, and instead of being a disc prolapse, there was spinal stenosis? So this means that it's not just a disc pressing on the nerve, but the spine itself has degenerated so that the hard or bony bits of the spine are now pressing on that nerve. So the likelihood of that nerve becoming unpressurized and much less, because these are hard changes that have happened in the spine. So the World Federation for Neurosurgeons produced 2 interesting statements, and these again show the nuance of spinal pathology and writing prognoses for spinal pathology. So statement 1 says, actually only 1/3 of people with spinal stenosis get worse. So 2/3 either doesn't change or gets better. So that's not bad in terms of prognosis. Statement 2 is the interesting bit, and that's the bit that really needs to form the crux of any medical legal report on prognosis. That actually there are predictive signs of potential worsening of lumbar spinal stenosis. So again, I look at a lot of MRIs with the spinal surgeons, but I couldn't identify these specific features by myself on an MRI scan, so I would need support from a medical expert who has a background in radiology, or from the spinal surgeons. And then you may be able to say, well, most people with spinal stenosis stay the same or get better over time. Actually, in this case, there were markers for worsening of lumbar spinal stenosis. So there may be an argument that there would have been some nerve pressure, nerve damage, or disability related to nerve pain in that left leg, regardless of what happened subsequently, and particularly with regard to delayed diagnosis and surgery. So just shows why it's so important to get someone who has an interest in spinal pathology when reporting on these cases. So hopefully I've described to you all about spinal pathology, why it's really common, and why it's a particular burden both globally and certainly in Western Europe. I've talked to you about diagnoses and why I think ICD-11 is really useful in medical legal reports. And we've talked a lot about prognosis and some of the nuances that one has with regard to that. So that's the end of my talk. Hopefully that was of use to you all, and I'm looking forward to answering any questions.
Hi, everyone. So thank you very much, Dr. Malhotra, for that. If there are any questions that people would like, there's a couple which have come through already, but please use the chat or the Q&A function above, as we're talking about the couple of questions we have. I can see there's a quick question here. If an orthopedic expert is given a prognosis of 3 years of knee pain and then ongoing symptoms, being associated to arthritis, but the expert says he can refer to a pain management for further comments, would it be justified to go to the pain management expert after an orthopedic diagnosis given? I think I can probably jump in on that one and to say, obviously, if a previous expert has recommended a further expert, then yes, clearly you could jump in and find a pain management expert to provide a further opinion in relation to that matter. So hopefully that one answers it to you. I have another question here before, if we're waiting for anyone else, and it's about identifying exaggeration. And I know you touched on it, but I'm wondering if you can sort of just give a little more in relation to that.
Yeah, thanks, Leo. Yeah, that is one of the very difficult things in medical legal work, identifying exaggeration or fabrication. And ICD-11 is quite useful, and because it does give diagnostic criteria for what is thought to be exacerbation of somatic symptoms. There used to be, or that even in some circumstances, there are people who use what were termed waddle signs. So you may see that in medical legal reports, and these were meant to be signs that, if were present, were more likely to suggest fabrication or exaggeration of symptoms. But waddle signs are not validated at all in differentiating between permanent pathology or pathology and exaggeration of symptoms. What I'd say is that often it's a constellation of things that requires an in-depth review of pre-existing medical notes and the results of interventions post-index event. So the GP records are really important. Physiotherapy records are really important in identifying the reaction of people to physical treatment. So how people, and it can go down to how people mobilize into a room compared to what they fill out on a questionnaire. And looking for those discrepancies are really important, particularly early on in a claim process, because it's important that we identify that early, both from claimant and defendant point of view. So I'd say there's no one way in which you can answer that question. It is often a constellation of things that you need to be a bit of a detective about, and to be fairly detailed in your assessment of these records. Some things that can be quite useful in identifying how much pain someone has, and then the impact of the pain on different levels of their quality of life. So actually, what impact has it had on work? Has there been any changes in their work hours? Have they had to make adaptations to work? Have they had time off sick? And reports from work can be quite useful in identifying discrepancies, because I think there's not many people out there who completely fabricate their symptoms trying to get a big payout. I think sometimes there is unconscious exaggeration, and I think that may be more common than fabrication. And the only way to get that amount of detail and that diagnosis is with scrutiny of the records before and after.
Thank you. And we have another question here. Can multiple attempts of epidural injections cause a spinal cord injury? So multiple attempts in spinal interventions are very unlikely to cause spinal cord injury, but they can, because when one performs an injection, commonly it's an epidural or nerve blocking injection, we use X-ray guidance, but X-ray guidance only really tells you the bony landmarks. You can't see nerves on an X-ray, and you can't see spine on an X-ray. So there is a risk with any spinal procedure of damage to both spinal nerves and spinal cord, and it's thought to be an increased risk if there are multiple attempts, just assuming that if the risk of one intervention causing spinal cord injury is 1 in 10,000, if you perform multiple, then just the statistics tell you that the risk is increased. But there are very specific signs and symptoms associated with spinal cord injury, and the crux of the matter normally is seeing if the signs and symptoms are located or can be located to the area where the spinal injection was going to be performed. For instance, if the injection is around a nerve in the lumbar spine, we know where that nerve supplies, we know the muscles it supplies. So if there's injury or deficits in that area, then you can make a stronger argument. But actually, if there are injury in area and nerves that are not near where the needle was going, then it's much more difficult to make that link. Thank you. And another one here, you referenced a study that showed that changed architecture in the neck from accidents at 10 miles per hour or above. Can you give further details of that study and how that is interpreted by pain consultants?
Yeah, so what they found, so it was a study looking at biomechanical changes in the spine, and it basically, what it showed is that there is, when you have an injury, and so we look at the bumper to bumper contact and we say, well, that's 10 miles an hour and that's associated with a certain amount of pressure change. And if you think of that pressure change, that's equivalent to someone running down the stairs or a big sneeze or cough. That's the kind of pressure change in the spine. But actually what they found was, when that happens in normal life, we subconsciously brace. So we brace the neck muscles and ligaments when we sneeze or when we cough. So actually, if you look at this study, it showed that whatever force was happening at the bumper, times it by 2.5 for the forces in someone's neck when they weren't expecting an accident to happen. And that is what the whiplash injury is, that kind of flexion extension or hyperflexion, hyperextension. And that can occur under very low bumper to bumper impact. And that's what this study showed. So what it showed was that there are soft changes. And remember, I talked about soft and hard changes. Soft changes associated with injuries at 5 to 10 miles an hour. There aren't hard changes, but for a diagnosis of whiplash, you don't need hard changes. You don't need an MRI to show any changes at all. It's very much based on descriptions of the index event, and often pictures can be really, really useful interpreting how much force we think was generated. But remember, anything that was generated bumper to bumper, times it by 2.5 for someone sat in the front seat with a seatbelt on who wasn't expecting the injury and therefore didn't brace.
Thank you. And another one here which has popped up: are you ever asked to comment upon weaning patients off medication? For example, if a patient who has already gone through surgery with no further surgery scheduled has been prescribed medication, such as, excuse me if I mess this up, but Oramorph, which continues to excessive doses, but pain is still not managed. So again, are you asked to comment upon weaning patients off medication?
Yeah, very, very commonly. And my work with the Medicines Management Committee is really useful in this, in that there are both professional guidelines on this and legal requirements with regard to prescription of controlled drugs. And there's been a sea change. So when I first started training, I was told opioids were good, in that they're really strong painkillers, less likely to be addictive than other medications. And I don't know if you've seen some of the documentaries on Netflix and some of the books. We can see that they were some of the reasons why we developed an opioid pandemic, particularly in the States and somewhat in this country. Now there is very much strong professional guidance on how opioids are managed, and generally, number one, not recommended for chronic pain, full stop. There are nuances to that, but that is the general recommendation. They should be used at less than 120 milligrams in any 24-hour period. So again, that is a Faculty of Pain Medicine recommendation. And if opioids are not resulting in improvement in pain or quality of life or function, they should be reduced and weaned off. And I probably spent the beginning of my career prescribing these medications, and now spending kind of the middle of my career deprescribing or weaning off these medications. It'd be a very common treatment plan as part of a medical legal report that I would write.
Wonderful, thank you. And again, here from Kimberly, can DISH or DISH be completely asymptomatic throughout one's life and then brought on or triggered by trauma alone?
So DISH is a type of degeneration of the spine, very, very common and very commonly asymptomatic. So again, as part of studies in asymptomatic patients, DISH is incredibly common. Its association with pain is quite interesting, and what we find is that the majority of the pain is related to myofascial pain. So it's often not the hard bits of the spine that are causing pain, but the soft bits of the spine. So if you have DISH and you have soft tissue pain, so you have myofascial pain, that can definitely be aggravated by an index event such as a road traffic collision, and it can be exacerbated in some circumstances or accelerated. DISH is becoming less common in terms of surgery for DISH. That's becoming far less common. And normally now DISH sits within the domain of pain medicine experts, because there are interventions such as injections and medications and psychology we can use to help manage DISH. So essentially, DISH can be asymptomatic, and it is in a lot of cases. If someone has DISH with soft tissue changes, road traffic collisions or high-speed index events can certainly aggravate that.
Brilliant. Thank you very much. I think that draws all of the current questions to a close. So just to highlight, obviously, before I close out, Dr. Malhotra is, of course, available for any specific case inquiries you might have, or for any more nuanced or specific questions you might want to ask him about some of your clients. Thank you very much for your time, Dr. Malhotra. It was incredibly enlightening. The recording of this will be made available within the next day or two, and we will, as per the last one, be sending out a very short questionnaire, which we'd appreciate if you can all fill in to give us some thoughts and some of your feedback on this. And there's already a few thank yous coming in from some of the solicitors here. So thank you very much, Dr. Malhotra, for your time today. And of course, yes, the slide deck will be available. We will make the slide deck available with the video recording in the next couple of days when we send it out. So appreciate everyone's time, and obviously we are looking forward to seeing you all at the next event in the next month or two, and we'll follow up with the details when it arrives. Brilliant. Thank you, everyone, and I'm going to log out now. So take care and have a great day.
Thank you all.